equity. Throughout these series of talks that we'll be sort of highlighting nursing faculty and practitioner leadership engagement in diverse health equity programs. We will also be featuring the application of nurses in community-based global health research programs. And also a third element that will be featured throughout these conversations is from the nurse's perspective, reflecting on the strategies and best practices of working with community partners. I also want to take this opportunity to highlight some of our co-sponsors or facilitators that are at both of these universities. We've got Dean Lorraine Fraser from Columbia University. We've got Tonda Hughes from Columbia University. We also have Jennifer Dohrn, who's actually going to be our speaker for today, as well as Linda McCurry at University of Illinois Chicago School of Nursing. A couple of sort of basic things that we wanted to highlight as we jump into this discussion is that for participants to mute their computers so that we don't have any sort of background noises. And then also to, when you're ready, we'll be taking, we'll have a Q&A after Dr. Dohrn's presentation. And so we'll ask of you to post your questions in the chat feature. And from there, we'll be able to sort of move forward with answering your questions. So Dr. Dohrn's talk the title is Nurses on the Front Lines of Pandemics, Recommendations for Effective Response from the Ebola Epidemic in Sierra Leone and Liberia from 2014 to 2016, as well as the recent COVID-19 pandemic in 2020. Dr. Dohrn is an associate professor and assistant dean of the Office of Global Health Initiatives and is Pahuan WHO Collaborative Center for Advanced Practice Nursing at Columbia University School of Nursing. As director of the Midwifery Services, she initiated the first freestanding maternity center in an inner city in the United States in the Bronx, New York. She has worked in sub-Saharan African countries since 2003, helping to expand the role of nurses and midwives in primary and HIV care. Dr. Dohrn was the founding project director for the United States PEPFAR-funded ICAP Global Nursing Capacity Building, which provided technical assistance to building nursing and midwifery capacities in 10 sub-Saharan African countries in response to the HIV pandemic. So Dr. Dohrn is currently leading an initiative to study the roles of nurses in pandemic responses through gathering oral histories of nurses who are working on the front line, who worked on the frontline cases of Ebola outbreak in Western African countries and midwives responding to COVID-19 pandemic in New York City. She has integrated her global experiences in complex humanitarian emergencies and racial injustices into 2 decades of teaching in midwifery and global health equity. So we want to take this opportunity to welcome Dr. Dohrn.
Thank you, Rohan, and thank you to all of our collaborators at University of Illinois Chicago College of Nursing. And I'm honored to be speaking today to all of you on a very exciting collaboration that we hope will engage many of you in areas of global health research, a focus on research. Today, I'm going to be speaking on nurses on the front line of pandemics, recommendations for effective response from the Ebola epidemic in Sierra Leone and Liberia, and COVID-19. And this is a picture, a little did we know, which I'll say many times, when we started doing this in 2016 and looking at Ebola, little did we know the state that we would be in today, having passed tragically 500,000 deaths of citizens of the United States and too many deaths around the world. Little did we know that pandemic response would become a code word for every one of us involved in nursing education. I want to note for a moment this picture because this is a picture of a nurse on the right in full personal protective equipment, holding the hand of a woman who's fighting Ebola. And it is symbolic. I like this picture because it's symbolic that we always maintain, however we can, human touch and looking at each person as an individual. So in starting, I wanted to just take a moment to honor all of the nurses and midwives around the world who've been serving in the battle against pandemics, from HIV to Ebola to COVID-19, following the giant footsteps and tradition of Florence Nightingale. And I have on the upper left-hand corner nurses in Eastern Cape, South Africa during the HIV pandemic, which I was a participant with nurses since 2003. And this is a community health center welcoming a new baby. On the bottom left is a picture of nurses who gave their lives fighting for Ebola in Liberia. And when one enters in Monrovia, Liberia, the Nursing Registry Council's office, the first thing you see is this wall with everyone's pictures. So it's a constant reminder. And on the upper right-hand corner are nurses in Wuhan, China, who were marking International Nurses Day a year ago in May. And on the bottom right are nurses in New York City preparing for their night shift during the COVID-19 pandemic. So I begin today with posing to this premise that for a robust response to pandemics, nursing is key to what works, what is essential, and what is achievable. So we need a robust nursing force in response at all levels to have successful response to pandemics. So managing infectious diseases outbreaks, it's really one of the greatest challenges of our lifetime. It certainly has defined my whole professional career as a midwife and as a nursing educator. And it's a heightened urgency in our increasingly interconnected world. As Dr. Tedros said yesterday on a conference I was with him, the Director General of the World Health Organization, he said, an outbreak anywhere affects the whole world. And to have a global pandemic requires global response. So more and more we are going to be shaped with many, many other interconnected climate change, non-communicable diseases. We're still going to be seeing infectious disease outbreaks. When we get on top of COVID-19, it's not going to be over. There will be others. So our preparedness, our voice, our wisdom are very important. We are the largest cadre of the health workforce, and many countries the only available providers. But too often we bear the highest burden of death among outbreaks, epidemics, and global pandemics. So Columbia University, we asked the question, what do nurses on the front lines of pandemics recommend for guidelines for policy response based on their experience? And from this question, a multi-school investigation was developed, which is called On the Front Lines, Nursing Leadership in Pandemics, with the objectives of understand and catalyze the role of nurses as change agents in response to infectious disease, and specific focus initially on the Ebola epidemic in Sierra Leone and Liberia, 2014 to 2016, through recordings and analysis of oral histories. And then to summarize and synthesize these stories and draw from them what would be guidelines for informing new policies and responses to deter, detect, and effectively control epidemics of the front lines of nursing healthcare. And now we've expanded this to include nurses' stories in New York City for a second investigation, which we're about completing. So these are the beautiful faces of all of the nurses in Sierra Leone and Liberia in 2019 that we interviewed and recorded their history. Our team, our journey, a delegation of nurses and midwives with expertise in pandemic management collected these oral histories, and it include colleagues from Zambia, Malawi, and New York City. And then we did this again in New York City. And on the left, you see a picture of our delegation with Sierra Leone's Chief Nursing and Midwifery Officer, Mary Fulla, who's the woman on the right of that picture. And in the bottom is meeting with Liberia's Chief Nursing and Midwifery Officer, Taria Kiwankpa. And our methodology is recording 39 nurses' stories in person in Sierra Leone and Liberia. And this is a picture, it's one of my most favorite prized pictures. This is a picture of Josephine Findeselu when I got to interview her in August 2019. When I was preparing a new course that I teach at Columbia University, which is Global Health Equity and the Responsibility of the Nursing Profession, and it was August 2014. And I was trying to decide what would be the theme that what I would carry throughout this course on the many issues of global health equity. And I opened my morning New York Times, and there was this picture of this nurse with tears coming out of her eyes. And this was Josephine Fiendeselu, who was the deputy nurse matron at a government hospital in Kenema, Sierra Leone, which was the center of the Ebola outbreak in Sierra Leone. And out of her staff of 24, when this picture was taken, 15 nurses had already died from Ebola. And she said at the time, even before this Ebola situation, I had given my life to this job to keep my people healthy. So when I was on this delegation and got to Sierra Leone, I asked Joan Shepard, our colleague who's head of the Nursing and Midwifery Association, is there a possibility I could interview Josephine Fiendeselu? Because everyone that's been through my class at Columbia, so now hundreds and hundreds of nurses that have graduated know about her, because I believe in remembering and giving honor, and when we're in moments of crisis, calling up their faces and remembering they stood up under incredible odds. So she said, oh yes, I'll get her. So the first day of interviews, no Josephine. So the second morning, I'm sitting preparing, and in walks Josephine Fiendeselu. I think I was like a groupie because I was so excited to meet her. She had no idea who I was. So I pulled up a picture here from my course to show her. And this began a long time friendship with her, and it was such an honor to meet her and to say in person, you changed us, you changed the world, to give her that recognition for her fortitude. And her family at the time had begged her to flee, to not go to work, because the death rate was the highest among nurses responding to the Ebola pandemic. And she said, I have a job to do, and this is where I will be. So what are some of the themes that we collected from these oral histories and are looking at how we summarize and synthesize? So the first one I would say was the criticalness of knowledge and access to infection prevention and control measures. And in Sierra Leone and Liberia, nurses repeatedly described the critical need for knowledge about the virus, its method of transmission, access to personal protective equipment. Seems basic to us now, but if we don't know the nature of this virus and its transmission, we cannot protect ourselves nor the communities we serve. They had slow access initially to PPE and how to don and remove. Many became infected because of this lack. And a quote from one of the nurses we interviewed: when we had this outbreak, I bought the PPE. I bought it with my own money. I bought the boots with my own money. I have my children. I have to go home and meet my family, so I don't want to infect my family. So I decided to buy these things. That was the state of things. And the World Health Organization and non-governmental organizations, ministries of health, were initially completely overwhelmed in a stressed healthcare system. And the high fatality rate of Ebola, which was 60 to 90% of people infected died within 2 weeks, just stopped the ability to know rapidly, especially for nurses, the importance of PPE. Matrons shared their knowledge with their teams, being in hospital for all shifts to implement safe strategies to protect nursing workforce. Josephine Fiendeselu told me how she was on 24/7. She was on for each shift to make sure everyone was fully protected and was coping with the situation. Another theme was teamwork was redefined and changed for effective team response. I think this is a very important one to look at where we go in the future, because nurses reported in both countries that they worked closer and differently with doctors because the daily urgency demanded that the long established hierarchical order between doctors and nursing had to loosen. It had to be for effective response. So example was the protocol for entering in ETU, or Ebola Treatment Union. There was a ritual of everyone, the team that was going in, which would stay in a maximum of 2 hours because of the heat, would gather in a circle in a special room prepared with mirrors all around, and they would don their PPE and they would check each other around in a circle to make sure that no skin was exposed whatsoever. And then they would enter with defined roles of what they were going to do as that team. And no one left before everyone had finished their work on that team that day, that shift. They would come back out, they would take off the PPE, make sure everyone had sanitized properly, and then they would hold their hands and pray. So it became a different look of everyone's life depended on each other. And this gave nurses who had had experience quickly, since they were the front line of the workforce, the ability to perform at higher levels, fuller capacity, never outside of what they were trained for, but as experts that were fully utilized. And they were instrumental in teaching other members of the healthcare team. Another theme was that nurses gave vital information, education, and care to their communities. So at first, with little information given to communities about Ebola, and given the long history of colonization and of civil war, there was great fear in communities. And at first, nurses who volunteered to go in to work with Ebola patients were stigmatized because people feared nurses might transmit the virus. Many nurses reported that for the first few months, they had to sleep overnight at the hospital for fear that they would go home and infect their families, and for fear in the community that they were carrying the virus with them. But as they engaged and taught the communities about the virus, they were defended by the communities because they felt empowered in infection prevention control. The wonderful importance and gift of education, because once communities realized that nurses were in fact saving lives, they rallied to support them. And one nurse described, as they marched in the streets, they were greeted with, "Here come the Ebola nurses," a big change and acceptance and seeking out nurses in the community. Often at night when they would home, other people would come and say, "I think someone's infected in my household. Can you come help me?" Or a laboring woman would come saying, "Can you help me?" Because at the time, all the L&D units had been closed within hospitals. Hospitals were literally completely turned over to Ebola treatment units. Nurses stated that public health nursing and care for the community was a central part of their education. So their education in nursing schools involved community health as a centerpiece, something that is an issue here in the United States about how we strengthen our community health within our basic nursing education. There was frustration that they did not have a designated responsibility as part of the country's pandemic response protocols because they were the link to the community. And nurses described their role as the critical link in translating and implementing safe burial practices, for example, and in providing primary healthcare services. Both in Liberia and Sierra Leone, one of the strengths of their healthcare systems were nurse-run public health clinics throughout the countries. And this became, as the response grew, a main source of support for the community. Another theme was that nurses witnessed great suffering and death amongst their colleagues, their families, their communities, resulting in mental and emotional distress. So every nurse described with anguish and tears witnessing the deaths of their colleagues, their family members, their neighbors. One nurse told me, "I was gowned in the ETU and looked down to see my daughter being brought in. She looked at me and begged me not to let her die. I will never forget this." In fact, her daughter did live. And on the right, you'll see a picture of Nurse Fonte Buoga. And when he came in to be interviewed, he opened his sweater and showed me a t-shirt with the picture of his late wife, Hawa Kamara, who was a midwife. And she was caring for a patient who she suspected was infected with Ebola. And the doctor on the unit said that she wasn't infected and they should deliver her, which she did. And then she became infected. The woman died who had birthed. And Howell went home, and Fonte became infected, and then all 5 children became infected. Her sister became infected, her mother. Out of this, only 2 people survived, Fonte and his 5-year-old child. And he was still working through this trauma. I've since heard since the last 2 years that he completed a master's degree in nursing He's on the front lines of responding to COVID-19, but hearing their stories was really a very painful and sensitive time for all of us. And they told their stories as if they were reliving events from yesterday. This was 5 years ago when we interviewed them. And they would start to talk and would seem like we were right in this or had just finished. They sought solace through their commitment to the nursing profession and that this is what they were called to do. And many reported that they had not been healed yet. Another theme was the dissatisfaction with the lack of acknowledgement for these services and sacrifices. Nurses repeatedly said they had sacrificed as part of their nursing oath and loyalty to their people, and yet had not been adequately recognized. Fiscally, many went without pay because there was confusion between the Ministry of Health and NGOs as to who was paying them. Publicly, there were not ceremonies to honor them afterwards, and individually. And nurses kept saying to me, why did it take you 5 years to come here? Why have nurses not been recognized, compensated, and acknowledged for what we did? This must happen. And part of this project is, in fact, recognizing them now. Nurses wanted more involvement in policy and guidelines for pandemic response. Nurses told of many missed opportunities for more rapid response because their voices had not been included at leadership level. This was particularly true in areas of infection prevention control training and decentralization for effective containment and treatment, of going into the communities, developing mobile units rather than having everything clustered in the cities, and for engagement of the community, who historically have been most trusting of nurses. Questions to consider in this are, why are nurses not at policy level, which we are still pushing to do and have had some success. Hierarchical structure of healthcare with doctors at the top, the gender inequity, majority of nurses are women. If 60% of our health workforce globally are nurses and 90% of that 60% are women, where does gender inequity play a part in this? So going on to how this developed, we're in the middle of analyzing all of these stories, and in March is COVID, and we said we have to keep going and collecting stories from nurses working on the front lines of COVID. So a year ago, March, unfortunately a year ago, we started expanding our project to include interviews. You'll see the difference. Here I am with Dr. Kelly Bryant, who is director of our simulation teaching program at the School of Nursing. So now we're on Zoom. Instead of being in the same room, we're on Zoom recording these histories. And we recorded between May and June in 2020, and we recorded 25 stories. We then did a second round of recordings 6 months later to see where nurses were. And I'm just going to show you some of the similarities and some of the differences between looking at two very disparate regions and different healthcare systems. So when we look at criticalness of knowledge about and access to IPC, New York City nurses, they stated a lack of pandemic preparedness, both educationally and clinically, resulting in feelings of frustration at their competencies. So from the beginning, we were not prepared. The same issues as had been in Sierra Leone and Liberia. Nursing education was not dealing with pandemic preparedness, nor was clinical practice. Nurses reported changing protocols for PPE and limited access to them in early months of COVID-19. If we think back to last March, April, May, they were changing constantly. And so what was current that day could change by the next day as what was needed to protect themselves. And this created great fear and instability amongst the health workforce in New York City. They feared a shortage of PPE, and with lack of consistent national guidelines, states were left with the responsibility to provide PPE and guidelines, which caused great confusion and fear of exposure among nurses. When we look at teamwork was redefined and changed for effective team response. In New York City, doctors and nurses worked as close teams in emergency departments in the ICUs. There was no time for written orders. Everyone worked at their highest level of education training no compromise of quality of care. So nurses reported calling codes, changing ventilators, initiating medication and treatment. And this was done, again, not outside of our competency, but there was a different recognition, particularly from doctors, that all hands had to be on board. And that nurses, we were trained, we were educated, we had the capacity to give the highest quality of care and needed to be allowed to do that fully. When we look at vital information and education care to the community, in New York City, nurses described being called upon as experts for their communities, for information and guidelines as they changed. Many said this was a new role in a healthcare system with minimal attention to public health within the United States. On the other hand, there's not that same history of nurses being based within communities strongly throughout the United States, which is different than the situation in Sierra Leone and Liberia. On the issue of the great death and suffering that nurses saw constantly, very, very same results in these recorded histories. In New York City, nurses said they had no preparation for the volume of suffering and death they witnessed. Most did not know how to do postmortem care. I remember a nurse in another project we have, Circles of Care, at the School of Nursing, reported stating that she was a postpartum nurse, and last March she was transferred to an ICU shift for redeployment, and she was with a patient who was dying from COVID-19, and she said, I spent my whole shift just praying that that person would not die because I did not know how to do postmortem care. And then, of course, when she went home, she felt terribly guilty that she was really not able to be there in the capacity that was needed. They grieved at going through deaths with their dying colleagues. One group of nurses described their head nurse dying of COVID-19 and saying, at least we were with him, we are his family. Another nurse practitioner said to me, my eyes are always going to be looking for them, for those deceased. Nurses expressed dissatisfaction with lack of acknowledgement for their services and sacrifices. And in New York City, mixed responses from that. Nurses expressed surprise and satisfaction in their initial recognition in the news and the communities, especially with the 7 p.m. pot banging from windows that happened in New York City and happened in many places around the world. One nurse practitioner working in ICU said, when I left my shift and walked outside the hospital, I was greeted with a crowd cheering me. For a moment, I kind of felt like a hero. As months went on, many expressed dismay at recognition at national level, whereas doctors were sought for expertise. So you see the shift of doctors becoming more and more the voice of what expert response is, even though we are highly qualified to be in that same capacity. And again, nurses wanted more involvement in policy and guidelines for pandemic response in New York City. Dismay that guidance for response continued to rest with doctors. Nurses not sought for their own competencies in clinical care and holistic encompassing of each person in the context of individuality and community identity, something that is the heart of our profession. Nurses quickly connected to the COVID-19 pandemic in New York City. They connected this to the overall disparities and racism within the US healthcare system, which they thought should have been given more attention from the beginning, with more than 2 times rates of death amongst Black and Latinx peoples. And one head nurse told me, I told my staff I was going out to kneel in solidarity with those pressing racial injustice, and that any of them could join me with what they wanted. So more attention to connecting the issues that this pandemic was raising. So looking at beginning results, and we're still in the process of analyzing most of the interviews from New York City, but beginning with results, nurses who directly provided care in both pandemics, meaning Ebola and in COVID-19, stated they persevered in spite of the many deaths among colleagues from infection. because of a strong commitment to the nursing profession, and something that we really should take pride in and acknowledge, that we really have moral ethics within our profession that we pass on to our students and is integrated into all of our teaching, that we have a responsibility to care for all under any circumstances. Nurses in both regions with disparate access to resources nonetheless repeatedly spoke of inadequate recognition for their sacrifices. Many missed opportunities were reported in both areas in providing community awareness of and engagement during the pandemic. And there was consensus that infection control was essential as a routine part of nursing education. In fact, speaking again with the nurses and midwives in Sierra Leone and Liberia, they feel they have been prepared to respond to COVID-19 because they maintained the vigorous infection control measures that were put into place because of COVID, and they were maintained in clinics and hospitals over these years. So recommendations that we could look at in guiding new policies for response: disseminate rapidly knowledge about and access to IPC measures for new outbreaks to nursing cadre and the enlarged health workforce, because we must protect and maintain a robust health workforce. Redesign the framework for healthcare teams and their responsibilities with inclusive and flexible roles to maximize competencies in response. So we need expanded roles in decision-making and provision of clinical care based on our evidence. And this can model ways for new foundations for effective and just healthcare for all post-pandemic. Another is to designate and capacitate nursing cadre as the link to community for engagement and education about transmission, prevention, treatment, respectful practices for community values and beliefs, and mobilization. There is no effective response without an engaged community, and nurses are educated and positioned to do this with knowledge and experience. And all strategies must include a commitment to expansion of healthcare for people. It can get lost in all of our focus on containment, the paradigm of containment over control. Containment is more important over care than care. But unless people know they're going to get care, there can be no effective containment. Provide well-being services, physical and mental, emotional, to all cadres of the healthcare team during pandemic and afterwards, something that always gets put on the end of the list. And we are still beginning to see this iceberg of how deep the mental emotional stress is. There are nurses leaving our profession. There are nurses unable to imagine continuing to go to work day after day as this pandemic continues. So this needs to be built into how we support people doing this, and recognize nurses' contributions and sacrifices fiscally, publicly, and individually, and inclusion of nurses at top levels of policy development, guidelines, and implementation of strategies for prevention, containment, treatment, and recovery for pandemics. I want to say a few words about this project, and that's that we have really involved students in our nursing school and across Columbia, of all the multi-schools that are involved in this. So we have a student associate groups, and in this past year, 60 people applied and 35 were recruited. We could not take on more. And they work on our audit editing team, of looking at the transcripts, the history timeline team, publicity team. So they're really engaged with studying and looking at and hearing what nurses and midwives are saying. And we are about to launch our website, which will happen on March 10th. And it's Frontline Nurses. Luckily, we got that phrase before COVID hit, but it really is a way to acknowledge and give recognition to nurses and midwives who stand on the front lines. When I was in Sierra Leone and in Liberia, people kept saying, "When will you come back?" And I said, "I will come back. We will come back." We were planning a public recognition with the Ministry of Health, and this was to be in May 2020, which had to be postponed. So this was a way of having a very interactive website that can, in fact, show each of the nurses and midwives in their stories. So there's one with all their pictures, and you press on the picture, and up comes that nurse's story, and you press another button and you will hear her speaking or him speaking. We previewed it in Liberia 2 weeks ago, and the nurses and midwives were like, you really did it. I mean, we had to show each of them, bring up each of their speeches, because it is a way for everyone in the world to acknowledge. And we're very fortunate that Miss Elizabeth Eru, the top nurse at the World Health Organization, will provide opening for this website when we launch it on March 10th. So in conclusion, I want to say that Arundhati Roy, who's an Indian poet and activist, wrote, "The pandemic is a portal." And I keep looking at this because it goes deeper and deeper. So it really shows this pandemic, but a portal shows the deep ruptures within our society and across the globe. And it opens us to see what exists, its strengths and its challenges. So it gives a way of looking at what is the foundation that we have existed on and what can possibly happen. Where do we need to go from this? And certainly in the United States, this pandemic has unmasked the reality of a neglected public health care system in favor of healthcare for profit, an ineffective, delayed federal response. It has exposed the racial injustice, the legacy of racism, exclusion, and inequality historically built into and currently maintained in the US systems of healthcare. And so we need to look at this as acknowledgement and then rebuilding, structure up, foundation up. And I'm very pleased to share that the School of Nursing at Columbia University has taken this very seriously and are looking deeply at racism within our teaching, within our educational system, and how do we transform it to be an inclusive and equitable nursing school. There is no more time for missed opportunities when so many lives are at stake. We need roadmaps for pandemic response that build healthcare teams with all its members being supported to contribute at their maximum level and every member of society receiving equitable and just care. And I believe that nursing is ready to take our place. And I want to conclude with this beautiful poster I get to see when I do go in to my office at select days, which is outside our main hospital, which is a thank you to all nurses. And it takes up almost the whole wall outside of the emergency room. And there we are standing proud and being recognized. And in front of this, teams from the community, large amount of teams would stand and bang pots and applaud. And all the EMS workers, that everyone within the hospital who came out the doors, and to all nurses. So thank you.
All right, thank you, Dr. Dohrn. This was a great presentation. What I'd like to do now is actually open it up for our participants to write in or ask questions. We've got about 15 minutes or so, so feel free to use the chat function of the Zoom platform to submit your questions, and then I will read those questions out so that Dr. Dohrn can respond. Or do we just want to go ahead and be able to, oh, okay. So particularly from Gwyneth Melbrook, she asked, how are the oral histories being archived or preserved for COVID and Ebola, or from COVID and Ebola for future research and posterity?
So at New York, we have at Columbia University, we have a very strong Center for Oral Histories, which has been one of our collaborators and became into existence right after 9/11 and archived, I think, over 1,000 interviews with people in New York City. So they have been our leaders in training us how to do oral history so that we would all do it in similar ways, follow guidelines about how to do this, because the oral history is not a chat. It's really creating a space for people to talk. And very hard to do because you're really the listener and you want to build on things that people say, but you also want to go through spaces. I'm answering another question that's come up too, but you write out the silences oftentimes when we talk with someone and there's silence, we think we need to ask something immediately or respond to what they say. And sometimes you do, but more often you want to listen. And especially on this really sensitive issue, it's very important. So they are archiving all of the Ebola histories, and they're archiving all of the COVID-19 histories. I want to say, so that will be preserved. I want to say one more thing about one of the hard things I found. I love oral histories. I've done a manuscript from women who birthed at the birthing center. I was part of building in the South Bronx. I think oral history is my form of research that I most can easily get into because of my own personality and the way I engage with people. These were really hard to do in Sierra Leone and Liberia. People didn't know us. I didn't have time to say, let me just tell you a little bit about me. We were structured. Nurses took time off from work. They came in. We entered an office. There are 4 of us, each in separate offices. And they said, Jennifer, here's your first person. And someone came in, they sat down, and essentially you had 2 minutes to say something, and then you turned on your microphone. And they were asking them these really intense situations. So I did one, and I had to stop in the middle and get a box of tissues, because the long silences you'll hear, and the students learn this, you'll hear many long silences in these interviews. And the silences are either the nurse crying, me crying, or we're both crying. There was so much emotion. And what amazed me, I developed after the first 4 or 5 interviews that at least when we finished, if I didn't have a time in the beginning, I at least said to them something about my own history. That I had been with nurses and midwives in South Africa and many countries on the African continent during HIV. I had witnessed many people died. I had witnessed my colleagues died. I had experienced my own tragedy of death in my family in South Africa. I shared a few things about me because otherwise it was like, I was amazed that they were so open in talking about things so painful that many of them had wanted to seal up just to keep on working and raising their kids. And also, once there was the space, people did want to tell their story. They did want to be here. And when you then start to ask about what would you do different for policy, everyone had opinions. Everyone knew where they were missed, where they were not really included, where they were not, no one went to the nursing association and said, what should we do differently about the community? So they were upset and angry about it because they felt they could have given better healthcare and not everyone needed to die. And I think that's true a lot when we're not allowed a voice in policy, because we do have opinions from the care we give. Right? We learn from our research, we learn from our clinical care. So I may have answered several of these, but yes, these are being archived, and yes, there was a structured form. Though I kept going, varying, you start to do the structured form and then you get off on one place and you need to ask all the questions, but you also want the variation that comes with meeting with one person in front of you. And I did find even on this bizarre form of Zoom that the stories that I did with New York City nurses and midwives were as emotional. And one described it by the second interview. She said, after I did my first interview with you, I realized I had to go into therapy. And now I couldn't wait to get back and do a second interview with you, because I could tell you how I've changed. And now I can tell other nurses, I can see the person who's helping clean the floor, and I can see the person who's pushing the gurneys. I can see the blankness in their eyes. And I take a moment to talk to them and say, there's good health services here. I had to get help. Maybe you should consider it. So it's interesting how this thing builds, but this big void of not taking time to understand that people saw things that they never imagined they would see and had to keep going.
One of the great things I think about this whole sort of series is, as a matter of fact, that we're learning from each other. And through your talk, I've actually now discovered that we do have a shared sort of research interests and practice, because I do collect life narratives among refugees as well. And I do them over a series of time. And I have found out that over time, people begin to open up and share more, as I've had numerous conversations and interviews with them. So I think that's really kind of helpful. One of the things that I've noticed for myself is that when I've been sort of reached the end of collecting the data, there's sort of almost a detachment, anxiety of having to say, well, we don't have to meet anymore or anything like that. And so folks get a little bit uncomfortable because they love the idea of being able to come and talk and share their stories and perspectives. So I think that's kind of unique that you're also kind of talking a little bit about that. A question from Linda McCurry says, how are you, the interviewers and data analysis, managing the stress of hearing these stories? Taking care of yourself is so important to be able to do this work.
Yeah, this was a very good question. When we were in Sierra Leone and in Liberia, and then when I returned, I had nightmares for several weeks. And at night, I would sit with the other, they were good friends of mine, the other nurses doing the interviews, and we would try and share them, what was so painful, because we were on such an adrenaline pace to get through this. In the number of people we had to do, that it was very hard, and we needed each other to go through our own healing about it. The other thing to note, and in both countries, is that you could not talk to anyone with going immediately into the civil wars and what had happened before. So one night I was in a restaurant, it must have been 10 o'clock at night, trying to get some food with another one of my colleagues. And the woman who was serving us, we started talking about what we were doing. And in 2 minutes, she was telling us the story of the mutilation that happened to pregnant women under the Civil War. Mm-hmm. And I was so taken aback, because I was like, I can barely deal with any more suffering. And now this woman I just want to eat. But of course, my needs were just my needs. She wanted to tell about what she had witnessed. People don't want to hear horrible things. It's you can only do it a little, then you reach your maximum, but she needed to do it. So people were dealing with scars upon scars. And I think one of the important things, at least that in those two countries, that I can say is that this gave them a proactive way to respond. They weren't victims and watching terrible things happen to their families. They were also able to go and give care. Mm-hmm. And so when you raise that, of how did you do this? They also said, I remember the first day a little boy got to go home from the Ebola treatment unit. I remember when this person went home and we had to give clothes, because of course all the clothes were burned after we burned them to destroy an Ebola virus. After the person entered the hospital, we gave them new clothes, and they got 2 sacks of rice to take out, and they got, there was a process that I can do something. Mm-hmm. In the midst of all the horror, I am giving. And that's why a little recognition would have gone so far. You did do this. You really were our saviors. You really were the heroes. And it's recognition and policy, as well as the public recognition, but all comes together to say you're experts at doing this, and you need to be recognized. And it was it just didn't happen enough. And I feel like I'm so glad we're going to have a website. It's only one small thing, but to have people see themselves and realize everyone around the world is going to hear them. It's one small way of contributing, but we need to ponder this some more, since we are still in this pandemic, of how we do this within nursing education and nursing clinical work. I also want to say one other thing that's kind of a carryover is that I feel like it's a really, people raise the thing of oral histories, and it's a valid form of research. And I want to keep putting that in the context of, we did this series on looking at what global health research is being done between our 2 schools and how we can do more, and also within all of the networks. I see many of my colleagues from our PAHO collaborating centers on this call, and from the WHO Global Network. We really want to, it's important to recognize that this methodology provides some very valuable things. We go through the IRB in New York. oral histories are exempt from IRBs, but we had to check in the countries we were in to see if they had what requirements they have. So it's in the analysis of it and how you then come out with recommendations all take a long time, and it's rigorous, and it's a great way of the students being involved, of learning this form of research to carry forward.
Mhm. Yeah, I really can. I also really want to really emphasize how important it is about self-care, especially when executing studies like this. I found myself limiting the number of interviews that I could do per day when I interacted with refugees by saying only 2 to 3, because I knew how emotionally taxing it would be for me. And I had to build in a process of, once I left and went home, of really trying to sort of work on trying to rebuild myself through all that I've heard and was able to document. So it's really something I think folks need to really think about when considering engaging in this work. But I also want to emphasize how significant and important it is to capture those stories. I think one of the questions that folks asked was, how is your project funded?
So we were funded by the Centers for the Study of Social Difference at Columbia University. We got a grant, and then we got an extension. And then, of course, since it's it was a very small grant, but it allowed us the ability to travel there. It allowed us the ability for the equipment of how we would record and analyze. And then a lot is just the excitement of the project. So we now have the major center for developing websites volunteered its work at Columbia University to do this. And they've put in, they got so excited about the project. So it is networking a lot. And depending on, and having it be a multi-school project was very important, because we brought in people from School of Public Health and the School of Gender Studies and Oral History projects and medical university school. So many in the arts and history, it's been a hodgepodge of groups that got involved, but they each had their angle of seeing how to put this together. I think, with the support of Dr. Fraser, this has been a real promotion for nursing within the larger university, because it is about nursing. These are stories, oral histories of nurses, and then in New York City. So it's also put us in terms of oral history, the use of it for collecting evidence of how to respond to pandemics. We're called upon to do many things because of this collaboration, which is as it should be. But it's so it is small funded and was extended, and we could go for larger funding. I think there's an end to each project as it happens, and I think once we complete the analysis of the oral histories from New York City and we will write a paper on it, we will then go on to other things. You have to judge when something should keep going or not, but it could change.
Absolutely. So we're down to the last few minutes of this, but there's just 2 questions I wanted to pose. Someone, Abigail, has indicated that nurses from Liberia and Sierra Leone are now going through a second crisis. How accessible are psychosocial services for those nurses? The second question I can also ask of you is that when Yasmin has also indicated that I think that one of the ways that racism can be dismantled is by immersing into other people's cultures and gaining cultural competency. How did you get to know the people of Liberia and Sierra Leone on a deeper level outside of their trauma?
Both are good questions, probably take up more time than we have during this. I feel like in terms of taking care of emotional, mental health, that it's low on priority everywhere in the world. So, because of daily necessity being extremely hard, just recovering from the civil wars is a long process, and now recovering from Ebola, and now having COVID, that emotional mental health is always last on the list. And in fact, I think part of this modest project has a contribution, because it does give back recognition, so one can put it in context. We were there such a short time, and it's only one piece, so I do not think it's frontline. I think in the beginning, last March, April, May, everyone was scrambling to even deal with the emotional toll because the pandemic was so frightening in New York City, and we were having 900 deaths a day in the state. It was so overwhelming that went way down on the list. But nursing, and certainly nursing leadership at Columbia, but also at NYP, our backup hospital, rallied quickly to have pastoral care, to have group settings, to have mental health services available. But it did take several months to recognize, which is how it oftentimes happens, but we can't forget it because the pain is just too much. So in terms of that, and I feel like part of the deepening of understanding the devastating effects of centuries of racism in this world and in this country is shifting the dialogue to immersion in undoing things, to listening, to changing, and also to knowing the victories. I mean, the resistance struggles in the United States have been long-standing, long-standing since the initiation, since the genocide of Native peoples here, Native Americans, and the system of slavery that predominated and defined our country on every level and continues to. So it's a process of undoing and also learning the history of all of the forms of resistance and being willing to say this is where we draw the line. I mean, my own experience of just my life has been one that's been devoted to these causes, and I have found the profession of nursing to be the vehicle through which I can be most effective. And knowing nurses, just getting to know people, going to live in places for periods of time, and then networking, meeting people. If that's what you're committed to, and if that's what you promote within your education to students, like our global program, which does integration, clinical integration in 18 sites. If you do all of this, it's a way of seeding and growing and nurturing, which is what we do as educators, the fullest kind of people going out to be nurses who really are ready to stand on the front lines.
Great. I stand correct there. Actually, we may have a little bit more time to be able to entertain some more questions. So if anyone wants to post any questions that they would like to sort of suggest, that'd be great. A question I probably wanted to ask of you is that as a result of the nurses that are on the front lines doing this work in Liberia, as well as in New York, COVID, has there been an increase among potential individuals who are thinking about careers in nursing as a result of seeing what nurses do? Have you seen that at all?
I missed the one part of, I got lost reading the things. The last piece about have I seen what right before that?
Yeah, no, I said, have you seen an increase in individuals considering careers in nursing as a result of the features of nurses during COVID or even during Ebola and stuff like that?
I guess that's a better question for my other colleagues who are on here. I think it's too soon to know. I know that admissions is not decreased in spite of the pandemic. People applying is higher than ever. I also know at our school that more and more students, way over the majority of students, come to Columbia because of global work and equity issues. So that's given how we when people are applying, one of the questions is why are you interested, and people telling us on exit. So there is, I think this is a very active, I mean, not everyone comes to school as real young, but a lot are, and a lot have been out and had, since it's an accelerated nursing program, a lot have had life experience, and people do want to stand up for the right causes and find nursing to be a very powerful way to give back on an individual level, on a community level, in a bigger way. So I think that we will see more and more people considering the nursing profession and coming into it with very defined ideas about fighting for justice. I mean, I feel our students are, when I taught last summer, the day I started this course, here we are with COVID, and the day before George Floyd was murdered in Minneapolis, and that became the course. We also taught, but we started every course right there. What had happened with George Floyd's murder and how many deaths. We had two topics that you carry through, and people were very engaged in this because this is life. This is what we were seeing, and it forces them back to, well, who are we as a School of Nursing, and how is our practice? So it is the portal, as Roy said. It is a portal to really deep examination and then taking action, finding ways to make things different.
Soliciting any more questions from the audience, if anyone wants to ask anything particular.
We might be done. We might have talked me out.
Yeah, sounds good. Well, it's been an excellent series, and I'm glad that we start off on a really great note with your work. I'm also going to put a plug to folks to consider looking out for our next talks that I think will be scheduled sometime in April or so. And ironically, it sort of piggybacks off of some of the stuff that we talked about today with regards to engagement with vulnerable populations. I think I'll be talking more specifically about my work with refugees, and also the use of qualitative methods and engagement to try to sort of understand how trauma influences their health-seeking behaviors. So once again, thank you all for logging in. A special thanks to Dr. Jennifer Dohrn for participating in helping us launch this program. It was great. And then also to all of our participants from around the world. I know it's not just specific to the United States that are all tapped in here, but thank you for logging in. Keep looking out for more announcements of the work that we'll be doing throughout this series. So thanks again.
Thank you to everyone. Thank you.
Great.